So we have papers, and the first question is perioperative anaphylaxis. And I have searched it on internet, and I found that perioperative anaphylaxis it is severe life-threatening generalized or systematic hypersensitivity reaction occurring during the perioperative period, characterized by rapid onset cardiovascular collapse, airway compromise, skin manifestations. Incidence is 1 in 10,000 to 20,000. Mortality is around 3 to 6%. And the morbidity will be bronchospasm, myocardial injury, hypoxic brain injury. And the common triggers. What are the common triggers? So, the most common trigger for intraoperative or perioperative anaphylaxis is neuromuscular blocking agent, accounting for 60 to 70%, succinyl, choline, rocuronium, and etrocurium. Then, on second, it is antibiotic 15 to 20%, beta lactam vancomycin. Latex have the third position of 5 to 10%. Gloves, catheter drains, colloids, induction agent, opioids, chlorhexidine, antiseptics, blood products, dyes. What are the pathology? Pathology is type 1 Ig mediated hypersensitivity reaction. Cross linking of Ig on mast cell, massive histamine release plus tryptase release, and these two cause vasodilation, capillary permeability increase, so they cause hypotension and edema. Bronchospasm, airway edema, myocardial depression via mediators, hypoxia acidosis. Non-Ig mediated also there is a hypersensitivity which is known as anaphylactoid reaction. Direct mast cell activation, which can be caused by opioids, contrast, and extern. Now about the clinical features. So in cardiovascular system, due to which is most severe, sudden hypotension, tachycardia, then bradycardia, then cardiac arrest. In respiratory system, first bronchospasm, increasing airway pressure, hypoxia, laryngeal edema. Cutaneous urticaria, flushing, angioedema, often masked under drapes. Another DIC, metabolic acidosis. So for the a tip to anesthesiologist, the first sign is sudden hypotension and raise in airway pressure. And what are the differential diagnosis? That is venous air embolism, mill murmur, drop ETCO2, high spinal total, local anesthetic, toxicity, bradycardia, hypotension, no bronchospasm. Myocardial infarction is EC changes in troponin rise. Drug overdose, dose relationship, delayed onset, septic shock, later onset, fever. Intraoperative management of algorithm based. Immediate step, we should stop the suspected agent like neuromuscular blocking agent, antibiotic, and colloid. Call for help, inform surgeon, maintain airway 100%, discontinue volatile agent, vasodilator. Trendelenburg position, leg elevation if feasible. First line is adrenaline 10 to 100 microgram bolus. Repeat PRN, then infuse 0.05 to 0.1 microgram per kg per minute. Fluid restriction of 2 to 4 liter rapid. Antihistamine chlorpheniramine 10 mg IV slowly. Corticosteroid hydrocortisone 200 mg IV. Bronchospasm salbutamol inhalational aminophylline 5 mg kg IV slowly. And what are the advanced? Arterial line plus ABG. Consider ECMO if cardiac arrest refractory to therapy. Stop surgery if possible. Post crisis management. Shift to ICU for 24 hours. Biphasic reaction possible. Serum tryptase level at event within 1 minute, 1 hour. After 2 to 4 hour baseline at 24 hours. We have to do serum tryptase level for first hour, then after 4 hour, then after 24 hour. Skin testing for allergic identification 4 to 6 weeks later. If serum tryptase is more than 25 microgram per liter, it confirms mast cell degranulation. Histamine, plasma, and urine supportive. IG testing, skin prick, identify culprit drugs. Complement are C3, C4 if immune complex suspected. What we do to prevent? We do documented allergy, clearly record and withdrawn, avoid cross-reactive agents, rocuronium and vecuronium, latex-free environment, pre-medication, H1, H2 blocker, corticosteroid pre-induction, test dose, so administration of antibiotics, colloid. As per ASC perioperative anaphylaxis algorithm, recognize hypotension, bronchospasm plus resist, stop, trigger 100% O2, call for help, epinephrine 10 to 100 microgram stat, and then repeat, fluid 20 ml per kg. Adjust antihistamine, steroid, and bronchodilator. Post-crisis monitoring, documentation, referral for testing. What are the drugs? Adrenaline 10 to 100 microgram IV. Bolus is first line. Then NORAD for refractory hypotension. Vasopressin 0.01 to 0.04 unit minute. Resistant shock. Hydrocortisone 200 mg IV. Prevent biphasic reactions. Chlorpheniramine 10 microgram IV. H1 blockers. Documentation will be time of onset, suspected agent, sequence of drug, vitals interventions, provide anaphylaxis card to patient for future anesthetic. Adrenaline early, save lives. Tryptase estimation, confirm diagnosis. Prevention by vigilance history, always investigate and post event. So our first question, perioperative anaphylaxis is covered with. Now we have high flow nasal cannula or oxygenation. High flow nasal oxygenation, and upon searching, what I have found, high flow nasal oxygenation is a method of delivering heated humidified oxygen at high flow. Rate will be around 30 to 70 liter per minute through a wide bore nasal cannula to provide precise FiO2 0.021 to 1.0, minimal positive airway pressure and dead space washout. So the precise FiO2, minimum positive airway pressure and dead space washout. This is also known as high flow nasal cannula therapy. The component of the system is the air oxygen blender. There is a heated humidifier and heated circuit tubing, prevent condensation and maintain temperature. Warm gases at 31 to 37 degrees Celsius, fully humidified, 44 mmHg of H2O, 44 mmH2O per liter. And wide bore nasal cannula, soft prongs up to 70 liter per minute. Mechanism, what it is: high flow rate, it meet or exceed patient inspiratory demand, stable FiO2. Positive and expiratory effect is a P-ply effect generated 2 to 6 cm H2O. If mouth is closed and alveoli recruitment will be there. Nasopharyngeal dead space washout, remove CO2 rich gases, improve ventilator efficiency. Humidification and heating, maintain mucociliary function, improve comfort, reduce airway resistance. Reduce work of breathing, decrease inspiratory effort and dyspnea. Apneic oxygenation during intubation, maintain oxygenation even without ventilation via diffusion. The flow rate will be around 30 to 70 liter, FiO2 will be 0.3 to 1, temperature will be 34 to 70 degrees Celsius, cannula size less than 50% of the nasal diameter, allow some leak. In critical and the respiratory failure, acute hypoxemia, respiratory failure, pneumonia, ARDS like mild to moderate post-extubation oxygen therapy, pre-oxygenation before intubation, apneic oxygenation during intubation, COPD exacerbation, selected cases, COVID-19 related hypoxemia, perioperative anesthesia, pre-oxygenation anticipated difficult airway, apneic oxygenation during intubation, thrive during awake fiber uptake, procedural sedation, bronchoscopy. Contraindications are complete nasal obstruction, facial skull-based trauma, unstable cardiorespiratory arrest. It is comfortable, precise FiO2 delivery, Mild PEEP effect improve oxygenation, continuous oxygen delivery during apnea, reduce need for intubation in mild ARDS, preserve speech, eating, and clearance of secretion. Now the disadvantage and the limitation: does not provide fully ventilatory support, limited CO2 clearance, may delay intubation if over relied upon, require power sources and humidifier setup, aerosol generation, risk of infection control. In monitoring, you have to do vital monitoring, observe sign of fatigue or rising PaCO2, APG after 1 to 2 hours, escalate for NIV or intubation if SpO2 is less than 90% despite of high FI2 more than 60%. Complication will be nasal dryness, discomfort, gastric distension, pressure sore, aerosol dispersion. So evidence summaries: Florali trials in which HFNO and NIV versus standard O2 in acute hypoxemia reduced intubation rate 36 to 24%, improved 90-day survival. Thrive technique: transnasal humidified rapid insufflation ventilatory exchange, extend safe apnea time up to 17 minutes during intubation. Special application: Thrive nasal humidified rapid insufflation ventilatory exchange, deliver 100% O2 at 60 to 70 liters during induction, maintain oxygenation during apnea, used in difficult airway obese in ENT surgeries, apneic diffusion and dead space flushing. So we can compare it with conventional NIV and HFNO. PEEP effect is minimal in conventional O2, then NIV is it is high, HFNO is a mild 2 to 6 centimeter we can provide. Tolerance is excellent. CO2 removal is moderate using during procedure, yes. So HFNO is a heated, humidified, high flow O2 via nasal cannula, and that's over. Now the next question is Sugamadex. Sugamadex is the new drug? No. It is used now everywhere except low socioeconomic countries in which India is also there. So what is about Sugamadex? It is selective relaxant binding agent, SRBA. Selective relaxant binding agent. It is a modified gamma cyclodextrin derivative introduced as a specific reversal agent for aminosteroid neuromuscular blocker. Structure is cyclodextrin ring is 8 glucose unit with hydrophilic exterior and lipophilic core. Okay, hydrophilic exterior and lipophilic core. 8 glucose rings. The lipophilic cavity encapsulated the steroidal unit of neuromuscular blocking agent like rocuronium acronium. So this encapsulation is the mechanism of action. So gamma dex bind in 1:1 ratio of complex. The concentration gradient shift, remove free drug from neuromuscular junction, drug diffuses out of the receptor, rapid reversal, independent of acetylcholinesterase activity, no increase in acetylcholine, hence no muscarinic side effect, unlike neostigmine. So drug reversed, aminosteroid ineffective in cysticercoid. Pharmacokinetic is onset within 1 to 3 minutes, elimination in the renal, half-life is 2 hours, excretion 96% via urine. So now the clinic setups: routine reversal, TOF more than 2, and 2 mg per kg. If D block PTC is 1, TOF is 0, 4 mg per kg. Immediate reversal, we need 16 mg per kg IV, all within 1 to 3 minutes. Recurrence prevention, minimum interval 24 hour, next steroidal NMBs. Okay, after 24 hours we can again give neuromuscular blocking agent like rocuronium. Rapid reversal of rocuronium can be done. Cannot ventilate, cannot intubate scenario, we can give rocuronium and then we can reverse Sugamadex. Daycare surgery, myasthenic patient, safety reversal in blockade, intraoperative neuromuscular testing. Advantage already we have discussed is fast, no neuromuscular antimuscarinic side effects, no recursion. Any kind of deep block can be reversed. It is safe, but it is little costly. Adverse effect is bradycardia, hypersensitivity, anaphylaxis, nausea, vomiting, dry mouth. Recursion interfere with hormonal contraceptive, renal impairment. So it interfere with hormonal contraceptive. Contraindication is severe renal failure because excretion is the renal, hypersensitivity to sucamadex or cyclodextrin. Avoid in pregnancy and lactation unless essential. Drug interaction bind other steroidal molecule like tormifene, hormonal contraceptive, fluoxetine. May interfere with the laboratory coagulation test APTT-INR. In pediatric, approved for more than 2 years, 2 mg per kg IV. Geriatric, similar dosing, monitor renal function, obesity, dose on actual body weight, not ideal body weight. Pre-intubation after sucamadex, wait for 24 hours, use benzyl isoquinolonium and MB cisatracurium. Storage, clear colorless solution of 100 mg/ml, stable at room temperature, single vial 2 ml or 5 ml available, which contain 200 mg or 500 mg. Rocuronium plus sucamadex, modern replacement of succinylcholine for RSI, no need of anticholinergic premedication. Use TOF to guide the dose. In renal failure, prefer nestagamine instead of this.